wonderful evening. Today marks an auspicious beginning of our ISAR Fertility Catalyst webinar series 2. It is a truly pleasure to witness the gathering of India's top-notch IVF experts on this platform. And each one of you are the catalyst in the field of IVF and gynae. That's contributing significantly to innovative medical treatment across the nation. Once again, I welcome to you all. We at UNS, we pride ourselves as one of the fastest growing pharmaceutical company dedicated to making major difference in lives of peoples and offering best class nutraceutical medicine. Our infertility portfolio includes brand names like CoQ300, CoQ-Man, CoQ-Fem, and CoQ-LC, as well as CoQ4, which helps the patient to empower their parenthood dream. With this, I would like to invite our medical head, Dr. Manish Garg, to introduce our chief guest and chief of honor, and to set the context for the today's proceeding. Over to you, Dr. Manish.
Sure. Thanks a lot, Apple. So indeed, at Universal NutriScience, we are proud to be associated with ISAR for this program, and would really like to thanks all the galaxy of stars and the speakers, as well as the chairs, moderators, and also are the chief guests as well as the conveners for this meeting. So this is the second webinar in our series, which we are collaborating with ISAR, which we have called the ISAR Fertility Catalyst. It's a short program. It's like a T20 match, 2 hours program. And this time we are blessed to have, apart from presence of Madam Dr. Asha Bakshi, Madam, as well as blessings of Sir Dr. Amit Patki, we also have Dr. Nandita Palshetkar and Dr. Bhaskar Pal as chief guest and guest of honor. What I'll do is I'll just introduce Dr. Anu Agarwal and Dr. Fesi, who have been the instrumental in helping us and have been driving this program. So as we all know, Dr. Anu Agarwal is an obs and gynec, and she is associated as the director of the Vansh Fertility and Test Tube Baby Center from a holy city within the country, that is Varanasi. Dr. Fesi Lewis also has been associated with this program and is helping with this. So Dr. Fesi Lewis, as you see, he is associated with just a not sure. So Dr. Fesi Lewis is professor and HOD of Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Science. So this brief intro, I'll pass it on to Madam Dr. Anu Agarwal for taking the proceedings further. Madam, I'll just share the slides and there you take it over, ma'am.
Thank you. Thank you, Dr. Manish. Wishing all of you an evening filled with knowledge and wisdom. I welcome all our esteemed doctors on behalf of ISAR to the second series of ISAR Fertility Catalyst, in which we are going to discuss all about PCOS. First, I would like to acknowledge our ISAR President, Dr. Amit Patki, who couldn't join today because of some problems, but he has sent good wishes to all of us. Our ISAR Secretary, Dr. Asha Bakshi, our Vice Presidents, Dr. Sunita Madam, Dr. Sujata Kar, and our immediate Past President, Dr. Nandita Palshetkar Madam. I'm honored to invite our vibrant ISAR Secretary, Dr. Asha Bakshi Ma'am, to say a few golden words. Asha Bakshi Ma'am.
Thank you, Anu, for taking this initiative. Anu and Dr. Fesi Lewis, you both are doing great job. And this type of programs are really very well liked because they are so focused. And your selection of speakers is so good. And I know the last program was also excellent and there were more than 300 participants in that program. So this series is doing very well. And keep going, and I'm sure we'll have more and more participants every time. And it is always so refreshing to see Dr. Nandita Palshetkar, who is our chief guest today, and she's going to give us some words of wisdom. And Dr. Amit Patki may join soon, but under his leadership, ISAR is really doing great job. And so nice to see today the program has been crafted very well. And I can see that Dr. Madhuri Patil is already there. And she is a master, a wizard in PCOS. And I really know that there would be so many learning points from there. And then Dr. Anupama Patil is all bubbly, and she's going to tell us about OHSS in ultrasonography. And Dr. Kundan is going to do the panel discussion on optimizing controlled ovarian stimulation. And again, he is also very active member of ISAR. And so nice that Dr. Anuradha Khanna, Dr. Fotela, and Dr. Veronica are joining as chairpersons. And very nice that this time all the panelists seem to be very young. And Dr. Ritika Gupta, Dr. Anchal Garg, I met her recently in Amsterdam, and Dr. Shivali Tripathi, Dr. Nupur Bajpayee, Dr. Shruti Mane, Dr. Pratibha Singh, Dr. Tamilavati. She's also one of the very active members, and Dr. Swati Gupta. So I'm sure this program is really going to go very well. And let's go ahead with the program. Thank you.
Thank you, Aisha Bakshi ma'am. Now I request our today's beautiful chief guest, ISAR past president, Dr. Nandita Panshetkar ma'am, to give us few pearls of wisdom. Please, Madam CV's.
No, thank you, Anu. It's okay. No problem. This crowd already is familiar with me. But thank you
Yes,
so
ma'am,
much.
you don't need any introduction, ma'am.
No. I think, first of all, I must congratulate you, Fertility Catalyst series, Anu and Fessy. It's really wonderful to see ISAR, doing such fabulous academic activities. And especially headed by Amit, and Asha is also a very strong support to him. So I'm really happy to see Asha everywhere in all the ISAR programs. So I think that is what the commitment of people is towards the organization, and it is very, very important. My dear friend, very, very dear friend Bhaskar is here. Actually, he calls me sister. So I think I can also call him my brother. He's here. And after he's come back from a rally, and I think uh, everybody all over the country are totally with you. And we are very aware of what you are going through in Calcutta because of the heinous episode. So we are very grateful that you could come and talk to us. Let me just say hello to Dr. Madhuri, Dr. Anuradha Khanna, Dr. Anupama Patil. And I want to thank UNS. I think Dr. Manish and and Mr. Nakul, I think it is. So thank you very much for being so supportive towards it. I think PCOS Day was done on 1st September, and 1 in 10 women of the reproductive age group have PCOS. And please note that nearly 30 to 40% of them have difficulty in conceiving. And there are so many phenotypes of PCOS, and so much the treatment needs to be varied. Especially I find it very difficult of the resistant PCOS where they just don't ovulate. And I'm sure you're going to target that. And there is, we are going back to the thing of wedge resection in a few cases. It's not actually wedge resection, but it's disruption of the hippo pathway. And that will release the oocytes and allow them to, allow this person. So in certain cases, yes, we need to do drilling. And I think that's what's important. You need to select your patients. You need to do the AMH. AMH is today in the latest international guidelines of 2023. They have said that AMH should be utilized along with the other markers for the diagnosis of PCOS. And it's very important when you have to decide the therapy. I think it is a very good marker which helps you decide the therapy. And I hope that, you will talk about insulin resistance, which is very, very prevalent in our country, and the different therapies that are available, and the obesity which is associated with 60 to 70% of the PCOS. So there are many factors which need to be addressed. I'm sure the CME will address it, and I'm really happy. And thank you for the honor for inviting me as a chief guest. So I won't take too much time. You can go ahead with your program. And it was a real pleasure to see everybody, especially Bhaskar. I'm seeing him after a long time. Not very long, actually, but yes, it's always a pleasure to see him. Thank you. Thank you very much.
Thank you. Thank you so much, Nandita ma'am, to join and give us blessings.
And I'm really sorry I have to exit at this point. Sorry. Thank you.
Sure.
I just want to interrupt. I forgot to welcome Dr. Bhaskar Pal. So, welcome Dr. Bhaskar Pal. And it's so nice to see you after the election. This is the first time I'm seeing you, and this is my opportunity to congratulate in person. So, heartiest congratulations and a warm welcome to you.
Bhaskar sir, it is such an honor to invite you as a guest of honor of Foxy President-elect. So a few
Thank you.
purposes
Yeah, thank you, Anu. Thank you very much. I was just wondering when Anu was introducing Nandita and Asha as a beautiful Dr. Asha Bakshi, Beautiful Dr. Nandita. I was wondering what she would address me by, but I saw that she skirted that issue.
You are a leader, a vibrant Dr. Bhaskar Pal.
Suraj, you are the rising sun now. You are the rising sun.
I am the odd one out here. I am not an IVF specialist, but I guess it is useful to have friends in ISAR, and that's why you get invited as a guest of honor. So I really thank Amit and Asha and Anu and Fesi for this. I wouldn't take too long, and I think everybody in this panel is more knowledgeable about PCOS than I am. But the PCOS is one subject that the more we know, we realize how less we know. But I guess it's wonderful that there are two very, very focused talks with two very great speakers. Madhuri, one of my favorite speakers to hear, and Dr. Anupama. And also, I think Kundan is a fantastic moderator, so I guess it will be a very useful evening today. And it's great to have it in the PCOS Awareness Month. And thirdly, is that I think we need to acknowledge that as much as we enjoy meeting one another and networking and in fellowship and sharing our laugh and sharing our coffee, I think we have to accept that the only good thing we inherited from COVID is our exploration of the virtual medium. And it is much more equitable. It makes education much more equitable and accessible. And so we need to see how we can marry the virtual and the face-to-face platforms together. Lastly, I'm sorry, I have to take this opportunity to speak about this, that you all know about the heinous event that has happened in Calcutta. But I just want to highlight that it has got three aspects. It is not only about a doctor being violated while on duty. It is also an issue about a woman healthcare staff being violated on duty. But the worst is that this has exposed a very deep underbelly that has been going on in some medical colleges in West Bengal, with a lot of political backing in the last 3 years. And in my lifetime, I've never seen such a spontaneous protest by citizens of the city who want to leave politics aside and come and do that. Every time a political party comes, they say, stay away. But we need, I think, everybody's blessings and support in this fight if we have to resurrect medical education in West Bengal. So our fight for justice continues, and we are hopeful. Our young colleagues have shown us the way. They're showing exemplary courage. We're just giving them the support. Thank you very much for inviting me, and I wish you all the best. Anu and Fesi.
Thank you, sir.
Thank you very much, Dr. Bhaskar.
I would like to invite my co-convener, Dr. Fesi Lewis, to invite chairpersons for the session.
Okay, good evening to all. I think without wasting time, we will go into we all are eagerly waiting to hear from the great speakers in the academic session. For inviting the speakers, first invite the chairpersons. First, we have Dr. Anuradha Khanna. Madam is the ex-head of Department of Obstetrics and Gynecology, BHU Varanasi. Was the president of UP chapter of UPGYN from 21 to 24, founder president of Society for Fetal Medicine, UP 21-24, ex-president Vox, founder president Varanasi Menopausal Society, organizing secretary UPCOG, ASCOG 2012, organizing chairperson UPCOG 2019. I think Madam has, I think those who have gone to any major conference in UP, we will be all, there will be a part of the planning and everything by the madam in that. We welcome you as a chairperson. I'm not going to read because of people are waiting for that. And next we have Dr. Anubama Fatela. She's a graduate from Lucknow, 1987 batch, master from MA MAMS, New Delhi, and fellowship in reproductive medicine from NUH Singapore. Honor and senior consultant of Fatela Hospital, Rudrapur. Gifted as first IVF
You can
babies
cut it
in.
out. Thank you so much. Enough.
Okay.
You
Okay.
can go ahead.
Okay.
Yeah.
So
Thank
next we welcome you, Dr. Anubama. Next we have Dr. Veronica Futela. She is the director of Veronica Irene and UL Fertility Clinic, and also national faculty of ISAR IFS Foxy, and currently joint registrar of Chhattisgarh ISAR, national secretary ISAR Chhattisgarh, and a member of Foxy Infertility Committee for many years. We welcome you, Dr. Veronica, for chairing this section. Over to you, the chairpersons for the session.
So I shall be inviting the first speaker. Can I see the CV for the first one? Doctor. Yeah. So we are inviting Dr. Madhuri Patil. Is ma'am around? Or we should invite the second speaker?
No, madam is there. Madam is there.
Madam is there. Okay. So
I think
Dr. Madhuri.
you can just tell the topic. That's all. I mean,
Yeah.
I don't think you need to read my
Okay,
CV.
so the topic is a very valid topic for interest of all the obstetricians and gynecologists here, and that's the pregnancy outcome in PCOS. There's so many things which we have to hear. What could be the implications of PCOS? Ultimately, all the infertility specialists are wanting this pregnancy only, and how would it be different? So we want to hear all that. Thank you so much, Dr. Madhuri, for being around. Welcome.
Yeah. Can I share
You
my
can
slide?
start your session now.
Just stop sharing these so I can share. Yeah. So at the beginning, I would like to thank Dr. Amit and Dr. Asha for inviting me here, and special thanks to Fesi and Anu Agarwal for inviting me to speak here today. And I would be speaking on pregnancy outcome in PCOS. So are women with PCOS at an increased risk of adverse pregnancy outcome? And I think all of us know that the answer is yes. And even the international guidelines published in 2023 said that women with PCOS have higher risk pregnancies, and all the healthcare professionals should ensure that PCOS status is identified during the antenatal care, and appropriate monitoring and support is provided. So it's basically a combination of several factors that results in pregnancy complications in PCOS. And these include infertility, insulin resistance, obesity, dyslipidemia, hypoandrogenism, and chronic inflammation, which can affect the oocyte and embryo quality, apart from directly affecting the pregnancy. And it has also been seen that oxidative stress with epigenetics and defective trophoblast invasion and placentation and disturbance of uterine blood flow in these women affect the pregnancy outcome. The placental dysfunction is basically mediated by androgen excess and insulin resistance, which may lead to adverse pregnancy, birth, as well as long-term developmental outcome in the offsprings. And it can increase the incidence of miscarriage, preterm births, and preeclampsia. It can result in fetal growth restriction, and also it can affect the developmental programming of the offsprings. And the fetal growth restriction and the developmental programming results in child and adult onset disease. So if you look at the pregnancy outcome, we know that the evidence, the recommendation is strong, though the evidence is low, that PCOS is associated with increased risk of high gestational weight gain, miscarriage, gestational diabetes, hypertension in pregnancy and preeclampsia, intrauterine growth restriction, small for gestational age babies and low birth weight, preterm deliveries, and cesarean section. We must also remember that ART does not confer an additional risk of miscarriage, preterm births, and impaired fetal growth and cesarean sections over that which are observed in women without PCOS. And this also has a moderate grade of recommendation, though the quality of evidence is low. And then we also need to remember that they do not have an increased risk of large for gestational age babies, macrosomia, as well as instrumental deliveries. So if you look at this paper, which was published in this year, we can see that there is an higher incidence of higher gestational weight gain as compared to the woman without PCOS, with the mean deviation being about 0.96. We can also see that the odds ratio for miscarriage in women with PCOS is 1.49, which is almost 3 to 4-fold higher than in those women who do not have PCOS. So what are the potential contributors to pregnancy loss in these women? One is obesity, which is an independent risk factor for spontaneous abortions. We have then placental thrombosis, because it has been observed that more thrombophilic disorders are seen in PCOS women with recurrent pregnancy loss, which is about 70%, as compared to 47.8% in non-PCOS recurrent pregnancy loss. And it has also been associated with elevated plasminogen activator inhibitor 1 activity, which is an independent risk factor for pregnancy loss in these women. Endometrial defects are seen, and this is basically related to deficient secretion of endometrial proteins, which may contribute to pregnancy loss. There's also abnormal secretion of glycodyline and IGF binding protein 1. Hypoandrogenemia is also associated with pregnancy loss. It is negatively correlated with placental protein 14, as well as glycodyline concentrations, which lead to abnormal endometrial development. Insulin resistance, again, is an independent risk factor for pregnancy loss, and higher fasting blood glucose, fasting insulin, and lower insulin sensitivity is seen in patients of PCOS with recurrent pregnancy loss. And the insulin resistance is seen in about 24% of the women with recurrent pregnancy loss versus 8% in controls. And the odds ratio is as high as 3.6. We must remember that the PCOS morphology is not predictive of miscarriage or live birth rate in these women who have had recurrent pregnancy loss. The maturin-like protein also, which is a marker of glucose homeostasis and inflammation in PCOS, has inverse correlation with recurrent pregnancy loss. Hyperhomocystinemia is again associated with recurrent pregnancy loss, and it has been seen that high AMH levels in PCOS population with miscarriage as compared to PCOS with successful pregnancies, and the chance of miscarriage increased by about 90.8% for every 1 nanogram increase in the AMH level when the AMH values were more than 6.1 nanograms per ml. Here in this paper published in 2021, we can see that in those women who have had previous miscarriage, the risk of having a subsequent miscarriage was significantly higher in those patients who had diabetes mellitus as well as dyslipidemia as compared to the other comorbidities seen in women with PCOS. Let us see whether metformin therapy would help in this group of patients. So basically, we need to know that GTT screening is required in all patients of PCOS who have a risk of recurrent abortions, and a positive effect of metformin therapy in the treatment of abnormal glucose tolerance, regardless of the presence or absence of PCOS symptoms, is indicated. And in this paper, which was published in 2008, you can clearly see that the abortion rate significantly decreased in both PCOS as well as non-PCOS women who were given metformin, whereas those women who were given placebo, there was no decrease in the abortion rate. And this was another paper in 2021, and you can see that the incidence of miscarriage was almost 33.8% as compared to 4% in the controls, that is those without having PCOS. And when metformin was given, there was a significant decrease in the miscarriage rate. And according to the ASHRAE guidelines, assessment of PCOS fasting insulin and fasting glucose is not recommended in women with RPL to improve the next pregnancy prognosis. And this was a strong recommendation, though it was having a low quality evidence. But then this consensus, which was published earlier, have said that in women with RPL and PCOS, the associated endocrine and metabolic pathology should be assessed and treated, and it has a moderate grade of evidence. So I think all of us know and will agree that probably all the women with PCOS, we need to investigate them for the endocrine and metabolic pathologies. Coming to gestational diabetes, we know that there's almost a 2 to 3-fold higher incidence in the woman with PCOS with the odds ratio of 2.41. And this is basically related to insulin resistance, which can increase in the presence of obesity due to increase in the TNF, interleukin 6, and leptin decrease in MCP1. And also, it could be related to abnormal placental hormones, which include HPL, growth hormone, CRH, progesterone, and adipokines. And this insulin resistance, in turn, then increases the incidence of GDM in women with PCOS. This was a study which was published as almost in 2014, and it was called as the COPPER study, which means complications of PCOS pregnancy, evaluating the risk. And they looked at 5 screening parameters, and a score was given for each of them for prediction of the risk of GDM. This included presence of type 2 diabetes in the first degree relatives, fasting glucose levels, fasting insulin, androstenedione, and evaluation of SHBG. And these scores were then totally put together by adding all the subscores for each screening parameter. And this then can be matched on the risk chart in order to obtain the predicted probability of a woman to get GDM. And therefore, this paper concluded that with this prediction model, one can accurately identify women with PCOS at risk of GDM before conception. So then, thus metformin basically helped when we continue it during pregnancy in reducing the incidence of gestational diabetes. And the answer we can find in this international guidelines published last year, that the answer is no. Because it has been shown that metformin in pregnant women has not shown to prevent gestational diabetes, late miscarriage after 12 weeks, hypertension in pregnancy, preeclampsia, as well as macrosomia or high birth weight. And it's a strong recommendation with low quality evidence. But it has definitely shown to reduce the incidence of preterm delivery and limit excess gestational weight gain in women with PCOS. One must also remember that these women then should be counseled that the consequence of metformin exposure on long-term offspring health remains unclear. And there is a suggestion of increased childhood weight, although causality is not certain. The side effects of metformin are usually mild, transient, which include transient gastrointestinal symptoms and are not worse during pregnancy. And therefore, if there is a history of preterm birth previously, or we find that the cervix is shortening, one could start metformin. Coming to hypertensive disorders in pregnancy, we know that they include chronic hypertension, wherein you have a BP of more than 140/90 without proteinuria. You have pregnancy-induced hypertension of gestational hypertension, again, where the BP is more than 140/90 without proteinuria and usually seen after 20 weeks of gestation. You have preeclampsia, where the BP is combined with proteinuria. And you have preeclampsia superimposed with chronic hypertension, where there is a high BP and the proteinuria then develops after 20 weeks of gestation, and eclampsia, which is now quite rare in our practice. You can see the prevalence of hypertensive disorder as pregnancy is almost as high as 20% as compared to 6.5% in those women who do not have PCOS, and this is statistically significant. And this paper in 2024 again said that the incidence is 2.3 times higher with an odds ratio of 2.2. And this is independent of ART. So it doesn't mean that ART pregnancies have a higher incidence of pregnancy-induced hypertension or gestational hypertension. And if you look at preeclampsia, in women. Again, the incidence is higher with PCOS with an odds ratio of 2.3, but the odds for eclampsia is almost similar with the odds ratio of 1.6. So that means that PCOS does not increase the incidence of eclampsia in women with PCOS. And basically, it is related to increased oxidative stress, maternal vascular dysfunction, diffuse endothelial dysfunction because of insulin resistance, hypoandrogenemia, and atherosclerosis. There could be alterations in the inflammatory mediators, abnormalities in the renin-angiotensin system, as well as reduced placental perfusion. Again, when we look at the preterm births, we can clearly see that it is significantly higher in PCOS women. In all the on all the three groups, that is less than 37 weeks, less than 35 weeks, and 32 weeks, as compared to those women who do not have PCOS, and this is statistically significant. It is basically related to higher levels of inflammatory cytokines, which were found in the amniotic fluid of women in premature labor, and these underlying inflammatory mediators associated with PCOS may also contribute to predisposition to preterm birth. Women with infertility, which is a common association among PCOS women, may also contribute to a higher risk of preterm birth than spontaneously conceived pregnancies, and therefore increased antenatal surveillance and facilitated access to higher levels of perinatal and neonatal care are essential. Coming to the incidence of induction of labor, it was almost similar in both PCOS and non-PCOS. So PCOS has not increased. The odds for instrumental delivery was also similar in both the groups, and it was not increased in those with PCOS, even those who had GDM. But you can clearly see that the incidence of cesarean section was significantly higher in PCOS women as compared to those without PCOS women. So then let us look at the impact of the fetus of PCOS. And we know that it is basically associated with low birth babies, and the fetus can have intrauterine origin of the adult disease. And the spectrum of the low birth weight babies, it includes small for gestational age, IUGR, and very low birth weight infants, some of whom are not only born prematurely, but also have superimposed IUGR. And basically, the birth length and weight is less than 10 percentile, and does not and although IUGR infants may be small for gestational age, all small for gestational infants are not necessarily IUGR, and this is the fact which we need to remember. And you can clearly see that the small for gestational age babies are significantly higher in the PCOS group as compared to the controls. And IUGR is seen in about 10 to 15% of these women. We also know that the intrauterine environment has a potential to affect the offspring, and the PCOS, which is a possible source of androgen excess, crosses the placenta into the fetus, and in the postnatal life can result in reproductive and metabolic dysfunction. Basically, it has been seen that women with PCOS are more likely to have their daughters with PCOS, and fetal and or prepubertal androgen excess then programs the hypothalamic pituitary control of the LH and enhances the visceral fat distribution, predisposing to insulin resistance and anovulation. The other secondary genetic and environmental factors like diet may also interact with this underlying linear process. Heritability of endocrine and metabolic features both is seen in the children of PCOS mothers. The endocrine and metabolic dysfunction during pregnancy can also affect the gene expression in the offspring by epigenetic mechanisms. And it has been observed that the testosterone concentration is high in the mid-gestational amniotic fluid, as well as the umbilical cord obtained from daughters of pregnant women with PCOS. Coming to induction of labor, as we've seen, the incidence is almost similar. That for instrumental delivery also is similar, and for cesarean section is higher. And this paper, which was published in 2020, looked at the pregnancy outcome and complications in women with PCOS diagnosis. And what they found is that the implantation rate, the clinical pregnancy rate, the miscarriage rate, the live birth rate as well as the preterm rate was significantly higher in PCOS women as compared to the controls, and this was statistically significant. Does lifestyle matter in pregnancy outcomes? And here you can clearly see that despite lifestyle intervention, there was no change in the neonatal as well as maternal complications seen as compared to the usual care which was provided. So then, does phenotype influence the pregnancy outcome? And we know that we have 4 phenotypes, A, B, C, and D. And it is the D which is not androgenic, whereas A, B, and C are androgenic. So this paper in 2017 looked at the complications, and what they found is that women with PCOS had a statistically significant increase risk of developing gestational diabetes with an odds ratio of 4.15 compared to the reference group, and the infants were also more often born small for gestational age with an odds ratio of 3.76. And when they did the subgroup analysis, they found that the maternal complications were statistically significantly more often present in women who had hypoandrogenemia, where the free androgen index was more than 4.5 compared to those with normal androgen levels, and this was statistically significant. And therefore, they concluded that women with PCOS have an increased risk of maternal and neonatal as well as pregnancy complications, especially in women who have an hyperandrogenic phenotype, that is A, B, and C. This was another paper in 2020, and they said that there was a higher risk of GDM, as we can see over here in group A, B, and C, which were again hyperandrogenic, whereas that for gestational hypertension, the risk was higher in group A and B, which were more severely hyperandrogenic. And if you look at the preterm birth, again, it was more in group A and B. Therefore, women with these phenotypes basically need more precise prenatal care. And if we look at the neonatal outcome, there was no difference between all the 4 groups. When we take into consideration the 5-minute Apgar, the neonatal weight, the neonatal icterus, neonatal condition, or NICU admission, or the anomalies, there was no difference between all the 4 groups. So then, does phenotype matter? And here we can, in this paper, which concluded that androgen concentration, insulin resistance, and inflammation positively correlated with GDM, and therefore all 4 phenotypes are prone to higher incidence of GDM than those with PCO and those with PCOM and oligoovulation, that is D, are least affected. There's also a higher incidence of hypertensive disorders in pregnancy, which are directly related to androgen excess, which result in endothelial dysfunction and atherosclerosis. And therefore, all phenotypes were equally and all 4 phenotypes were equally responsible for higher miscarriage rate as well as preterm births. And then this paper in 2022 said that adverse outcomes were seen in group A, B, and D. So here they said that C was not involved, as we looked at the previous one. Ectopic pregnancy was more common in A and D. Miscarriage was common in A, B, and D, whereas premature birth rate more was seen in phenotype A and B. And if you look at hypertensive disease, it was seen in A, and C, and that for all the other, and GDM was basically seen in A, B, and D. So basically, A, B, and D were independent risk factors for adverse pregnancy outcomes, according to this paper. Though the others have said, they have described D as having more risk of adverse effects, though it is not hyperandrogenic. Then this paper in 2023 looked at the pregnancy morbidity among these patients, and they concluded that there was increased chance of developing GDM, PIH, preeclampsia, and premature deliveries, and this was independent of obesity. And when they took PCOS phenotype into consideration, ovulatory, anovulatory, and hypoandrogenic had higher prevalence of GDM, gestational hypertension, and also preeclampsia, and this was again independent of obesity. And the prevalence of these outcomes was similar in women with and without PCOS if the BMI was more than 30. And if they used metformin, there was decreased rate of GDM, PIH, preeclampsia, and IUGR in contrast to what was published in the international guidelines in 2023. They said that it improved the insulin sensitivity in PCOS women treated with metformin, and there was 57% reduction in the free testosterone levels in these women when given metformin as compared to PCOS. When we look at the live birth rate, whether there was any relationship, so according to them, there was no statistical difference in the live birth rate between PCOS who had hyperandrogenemia and those who had normal androgen levels. And live birth rate was also similar in those with the recurrent pregnancy loss and those with recurrent pregnancy loss with PCOS. And it was also similar in those who had elevated testosterone as well as normal testosterone levels. So basically, this really did not make a difference in the PCOS phenotypes did not make a difference in the live birth rate. And when we look at metformin, they concluded that live birth rate was significantly increased in PCOS women treated with metformin as compared to PCOS women without metformin, and most beneficial effects were seen in the obese women. And when we look at the neonatal outcome, there was significantly lower birth rate of babies from PCOS mothers with no macrosomia, and these had more frequently admitted to the NICU and had significantly increased perinatal mortality compared to non-PCOS controls. And there was also no difference in the APGAR score seen between the two groups, but there was a higher prevalence of jaundice and IRDS, and the chromosomal abnormalities are also basically almost similar. And this paper in 17 looked at the neonatal outcome. And here you can clearly see that the cesarean delivery, preterm births, APGAR score of less than 7 at 5 minutes, birth weight of less than 2,500 grams, as well as the stillbirths and perinatal mortality was significantly higher in the PCOS as compared to the non-PCOS, and all this was statistically significant. I would like to add a word because now we know that we've started using the GLP-1 and agonist to reduce the weight, and we know that it is a category C drug and therefore should be avoided during pregnancy and lactation, and it's not basically transported across the maternal fetal placental interface. And therefore, whenever these drugs are used, we normally advise contraception, and we also wait for 2 months for the patient to conceive to give a washout period. So it has been seen that GLP-1 agonists reduce the fetal survival, weight growth, as well as skeletal ossification, and they can also induce major congenital anomalies, whereas the SGL2 inhibitors cause dilatation of the renal pelvis and tubules and congenital anomalies, and there's also an increased rate of miscarriage. And there's a lot of scarcity of data when it has been used in pregnant women, because usually we advise contraception. But there were 2 papers now which were published, and what they said is that basically exposure to both these drugs during pregnancy was not associated with risk of major defects when compared with diabetes and also overweight. So these were the main causes for the associated defects. And then they also said that GLP-1 group, the cumulative incidence of live birth, pregnancy loss, and pregnancy termination was 59%, 23%, and 18% respectively. And this paper said that infants born to women with type 2 diabetes treated with second-line or the advanced oral anti-diabetic agents, a greater risk of congenital malformations was not seen after conceptual exposure to these drugs, and as compared to insulin, and therefore they said it's safe. But both these studies which were published this year had a low number of subjects, so we required further studies really to prove that inadvertent use of GLP-1 as well as SGLT2 agonists during pregnancy is safe. So what do we recommend to improve the pregnancy outcome? So pre-conception, we have to assess the BMI, BP, and OGTT. We have to advise lifestyle modification, correction of hyperandrogenemia and insulin resistance and hyperinsulinemia should be done. And according to the Indian guidelines, it's recommended that a pregnant woman should be screened for glucose tolerance in the first trimester. If normal, then again should be tested for GDM around 24 to 28 weeks using the DIPSY criteria, and finally around 32 to 34 weeks. Metformin can be used in the preconceptional period and during pregnancy as it is safe and effective. And myoinositol supplementation is still experimental but may be used. Early lifestyle intervention should be offered to pregnant women with PCOS given the risk of higher baseline weight, excessive gestational weight gain, and pregnancy complications. The blood pressure measurement should be performed when planning a pregnancy or seeking fertility treatment, given the high risk of hypertensive disorders in pregnancy and its associated comorbidities. And an OGTT should be offered to all women with PCOS when planning pregnancy or seeking fertility treatment, given the high risk of hyperglycemia and the associated comorbidities present during pregnancy. And if not performed in the preconception phase, an OGTT should be offered at the first antenatal visit and repeated again at 24 to 28 weeks. And these were the clinical practice points from the international guidelines. So I will end my talk by saying that PCOS are more likely to experience pregnancy complications which are independent of but likely to be exaggerated by increased age and BMI and by assisted conception. There are higher odds of miscarriage, EDM, gestational hypertension, preeclampsia, preterm delivery, and cesarean section, and are probably independent of the age and BMI. Induced and/or operated deliveries are indicated in high-risk pregnancies for mothers or offsprings. Babies born from mothers with PCOS may have increased morbidity and mortality, and underlying conditions and the interventions may both increase the risk of hemorrhage, infection, and rehospitalization post-delivery. One must consider PCOS as a risk factor for pregnancy complications in preconception and in the antenatal care guidelines to enable timely screening, proper monitoring, and early intervention. Eat less, eat on time, eat right, walk more, sleep well, and smile is the mantra in PCOS to avoid all complications before pregnancy, that is during the fertility treatment and during pregnancy. And I thank you all for a patient hearing.
Thank you. Thank
Can
you.
I ask you a question?
Yeah.
Madhuri, if you have got a patient who is severe PCOS and you have done IVF or IUI and she has conceived, so when would you stop metformin? She has been on metformin. So would you stop the metformin or would you continue the metformin?
Again, that is very controversial. So initially we thought that it is safe and we did continue. But now if you look at the international guidelines, basically they say that only if there's a risk of preterm labor, you should continue. Otherwise, there's no use in continuing. But I think there are other guidelines which say that probably you can continue. So probably it's very, very controversial. And I basically don't do obstetrics, so I don't know what happens later. I mean, if you continue and you don't continue.
I mean, initially the norm came that you continue if a patient is on metformin, and then later they started advocating that you stop it. Some would say stop it after 12 weeks.
But the recent international
switch over to insulin.
The recent 2023 international guidelines said that they should not continue.
Yes, some said you stop it, and
the international guidelines say you should not continue.
You should not continue.
Other guidelines which are again controversial, but the international guidelines published in 2023 says that you should not continue.
Yes. Well, that says that, it's still inconclusive because the guidelines, as we know, will keep changing. So
even the 2018 also said that it should not be continued. And in 2023 also, they have added many more RCTs and they have said that it should not be continued.
Well, it is exhaustive data, which you had compiled for us. Very good, Dr. Madhuri. There was one slide which was mentioning something about hyperhomocystinemia.
So they have said there are certain papers which say that hyperhomocystinemia in these patients increases the risk of miscarriage in these women who have PCOS.
So are these patients are more prone to have hyperhomocystinemia, or as it is hyperhomocystinemia, as it is, it's making patients prone of miscarriages?
No, PCOS is not prone to hyperhomocystinemia, but if the patient has homocystinemia, hyperhomocystinemia,
And
and
she will
PCOS,
definitely be.
they're more prone to pregnancy
That,
loss.
that is an independent risk factor. Okay. Thank you, ma'am.
Ma'am, in continuation to this, I mean, these patients in your talk also, you mentioned that they have a higher predispensity towards having atherosclerosis and placental dysfunctions. So, any role of blood thinners that we can add on to these patients to prevent miscarriages?
Yeah,
Or should we routinely use
no,
aspirin or low molecular weight heparin?
I don't think I use low molecular weight heparin, but aspirin, normally when we do the NT scan, we also look at the blood flow. So in case we find that there is a problem in the Doppler, we do add aspirin 75 in these group of patients.
So we should start it right from the beginning. I mean, as soon as they conceive, or like if it's an IVF patient or something from that.
Again, there is a lot of controversy in that. Some say you start it when the patient is pregnant. Some say you start it only if you have abnormal Doppler finding.
Until when should we continue it, ma'am?
Normally, it is given till 34 weeks.
34 weeks.
I don't think there is any role of heparin unless she has any other factor which advocates us to give heparin.
Right.
Dr. Madhuri, I would like to say something. It was an excellent talk, very thought-provoking and very informative. As already you have mentioned in etiopathogenesis, so many beautiful slides you have shown me regarding all the toxins and everything. So if you go in that line, one should give the enoxaparin and this low dose aspirin, but 150, because there are first wave and second wave of intravenous this is spiral artery invasion. So if it actually should be given, it should be the early first trimester. And in the early first trimester, there another point of view that already patient is not taking much orally. So we should avoid giving metformin. Otherwise, whole embryopathy will be affected. These are my feelings, and I'm sharing with you. Second, you have beautifully explained about the preterm labor. In this preterm labor, why it is low after giving the therapy is that we are correcting the adrenal of the fetal adrenal. This preterm labor is caused by the fetal adrenal cortisol level, and that is if corrected from the beginning, then patient is less likely to go in preterm labor, as you mentioned about the metformin. Dr. Asha Bakshi has very well talked. We are continuing. We have given her metformin, and especially if she is in obese, there is no harm in continuing. Of course, you can monitor the dose of metformin, because if lot of metformin is given, this will be the practice of all of us. We are getting more the cases of FGR. So we have to see how the embryopathy is going on, how the hormone content of ABCD type of phenotype beautifully explained. So these are my few feelings regarding which type. And then one question I would like to ask you, that regarding pre-pregnancy preparation, the androgen, which anti-androgen will you like to have? Spironolactone, danoprostrone, or sapropterin prior to she becomes pregnant? Just
No, I don't think if the patient does not have symptoms of hypoandrogenism, which are very severe and which have not basically, because most of these patients are anovulatory. So we would basically go for ovulation induction rather than, suppressing the androgens. Because when you are using anti-androgens, again, we do not advocate pregnancy. So unless before that she's got severe symptoms and she's not responding to combined oral contraceptive pills, then only anti-androgens are advised. And when the anti-androgens are added to the combined oral contraceptive pills, basically one must tell them to use a contraception and not advocate pregnancy during that point of time.
At least 2-month gap should be there before she becomes pregnant. And of course, hyperhomocystinemia also beautifully explained. And that's why such patient should have at least 3 months pre-pregnancy preparation of methylfolate, all the brands. And
so normally we do start, because most of them are anovulatory. So when they come, normally we do start pre-conceptual. Yes. And we normally also do oral glucose tolerance test, and only if it is abnormal, I normally would start metformin. And very rarely nowadays, if the patient is very obese, where she has a BMI more than 35, and though her glucose tolerance is normal, then in this group, I would start metformin, because now it has been shown that metformin improves in the live birth rate, especially when we are giving gonadotropins for ovulation induction.
Madam,
Thank you
we're
so
running short of time. We will
Yeah,
take
we
a
should go to the next session now. So, Dr. Anuradha, would you be kind enough to introduce Dr. Anupama Patil, our next speaker?
Sure, I will like to her CV. I'm seeing from mobile, so I will like to read as far as possible. Yes.
So she's a very knowledgeable
Yeah.
young, and I'm
So
sure.
it's my privilege to introduce Dr. Anupama Patil, MBBS MS gold medalist from KIM Ubai, Karnataka. She is consultant in reproductive medicine and Kritu Fertility Center, MBBS MS gold medalist, follow-up of the reproductive medicine, advanced diploma in ART, and areas are research interest. They are this fertility, ovarian, endometrial regeneration, ultrasound, endoscopic surgery, and she had many presentation and also has written chapter. So I would like to listen to Anupma Dr. Patil for your next celebration.
Good evening, all. I thank the organizers for this kind opportunity. After a very interesting lecture of Madhuri Madam, my topic is on assessment of OHSS by ultrasound and what are the high-risk markers by ultrasound. Ovarian hyperstimulation syndrome is a serious and iatrogenic complication of ovarian stimulation. When hyperstimulated ovaries are exposed to HCG, this situation arises, and it is characterized by cystic enlargement of the ovaries and shift of the fluid from the intravascular compartment into the third space. The risk factors include young age, lean individuals, black race, and polycystic ovarian morphology on ultrasound. High basal AMH more than 3.3 are at high risk for OHSS. High AFC of more than 24 follicles on basal scan. Rapidly rising estradiol level beyond 3,500 picogram per ml. More than 25 follicles at the time of oocyte pickup. More than 24 oocytes retrieved. Long agonist protocols and exogenous HCG trigger are the high-risk factors. We follow the international evidence-based guidelines for the diagnosis of polycystic ovarian morphology 2023, and PCOM being the high-risk factor for OHSS. We'll discuss this. The scan has to be done on day 2 to day 5 of the menses or any time when the lady comes with amenorrhea. Either of these three criteria diagnoses the PCOM. Follicle number per ovary more than or equal to 20, follicle number per section more than or equal to 10, ovarian volume more than or equal to 10 cc. Either of these three criteria in even one ovary diagnoses PCOM. It is better to do a transvaginal sonography. However, if the lady is not ready for it, we can even go for a transabdominal scan. So follicular number per ovary is the most effective marker. We have to measure the antral follicles in 3 dimensions, but practically it is difficult. So we measure only 2 dimensions. 2 to 9 millimeter follicles are called as the antral follicles. And this counting should be done in the absence of a dominant follicle or corpus luteum on day 2 to day 5 of the scan or any time when she comes with amenorrhea. The pattern of distribution may be peripheral or scattered distribution of the follicles. Immaterial of that, the number of follicles is important. The modified Rotterdam criteria had given 12 as the cutoff. The international guideline says 20 and above follicle number per ovary in either ovary diagnoses this condition. But there can be subjective error. We can measure the same follicle again and again. To avoid that, we can use 3D Sono AVC, and this will color code each follicle, and hence we can avoid counting the same follicle again and again. This can give an objective, correct measurement of the number of antral follicles and help us to diagnose polycystic ovarian morphology. Next important parameter is the ovarian volume. Anything above 10 cc is taken as a polycystic ovary. So this measurement has to be done in two dimensions, one focusing on the longitudinal diameter of the ovary and the other 90 degrees to it. So the three measurements are the longitudinal diameter, anteroposterior diameter perpendicular to it, and the transverse diameter. So some machines will automatically calculate the ovarian volume once we take these three measurements, or we can calculate it by multiplying 0.5 multiplied by these three parameters. However, we all know that the ovary is not exactly ellipsoid. We can use the 3D parameter of vocal to calculate the ovarian volume also. Ovarian stroma has not been included in the international guidelines, but studying the ovarian stroma also helps us in identifying which women may hyperrespond. The normal ovarian stroma is less echogenic than the myometrium, but in PCO ovaries, because of the increased ovarian stromal mass, because of the LH-driven increase in the androgen secreting cells, we find that the ovarian stroma is more echogenic. Even the ovarian stromal vascularity can be studied. The peak systolic velocity is very high compared to the normal ovaries. RIPI is low. We can even use the 3D parameters and study the VI, FI, and VFI of this ovarian stroma and detect which women will hyperstimulate. Coming to the ultrasound role during ovarian stimulation, we can identify women who are hyperresponding. If we find more than or equal to 18 follicles of more than 11 millimeter size, we can predict that she's a high risk for OHSS and avoid HCG trigger. At the time of oocyte retrieval, if we are finding more than 25 follicles, then also we can predict that she may go in for OHSS. We can classify based on the onset as early and late OHSS, that is within 10 days of the trigger, which is due to the exogenous HCG trigger, or late OHSS that occurs after 10 days because of the pregnancy. So late OHSS is after 10 days of HCG trigger. It is because of the pregnancy-associated endogenous HCG, often associated with multiple pregnancy. As we can see in the picture, there is multiple pregnancy with ascites. This is due to embryo transfer in a hyperresponding ovary. These cases are more severe. Miscarriage rates are higher because of the increased thrombotic tendency. So ultrasound also has a role in assessment and management of OHSS. RCOG 2016 has classified OHSS as mild, moderate, severe, and critical. Mild and moderate are when she has nausea, vomiting, enlarged ovaries, and moderate when there is ascites begins. Both are managed on OPD basis. So ultrasound has a role in identifying the presence of ascites and quantifying the ascites. Severe and critical needs inpatient management. Severe is detected when there is clinical ascites and oliguria, hematocrit raised, and electrolyte imbalances. And the ovarian size is increased beyond 12 centimeter. Critical is when there is tense ascites and other major complications. So as we have amniotic fluid index in obstetrics, we have ascites index in OHSS, and we can use this to measure the amount of fluid in the peritoneal cavity. Four quadrants are taken, that is the two ilia fossa, the right and the left, and the two subdiaphragmatic areas, that is near the liver and the spleen. Measurement of the fluid should be taken perpendicular to our probe, and all the four parameters should be added to quantify the amount of ascitic fluid. This will help us to prognosticate whether she is responding to treatment. So indications for admission will be severe and critical OHSS. Now, there is a role in the of ultrasound even in the management of OHSS. That is, paracentesis is indicated under ultrasound guidance when there is severe abdominal distension, pain, not responding to anything, shortness of breath, and oliguria despite adequate volume replacement. Oliguria happens when there is tense ascites, when it compresses on the renal artery, decreasing the renal perfusion and causing oliguria or anuria. So there is a role of paracentesis, and it is done under ultrasound guidance either transabdominally or transvaginally. We generally do it transvaginally to avoid injury to the enlarged ovaries, which are also very highly vascularized. Along with paracentesis, we drain about 2 to 2.5 liters of fluid when we do the paracentesis, and we continue with the IV colloids, thromboprophylaxis, and all other supportive management. So there is a role That is, we have to identify the polycystic ovaries, and we have to identify that the woman is hyper responding to stimulation. We have to avoid HCG trigger in those who are hyper responding according to ultrasound, and we have to detect OHSS early and manage it. Thank you.
Wonderful, Anupama. There was a question from the audience that a lady has come with an AMH of 33 and she has come up for IVF. So how do we stimulate this patients and what precautions to be taken? Because this is another very high risk, high AMH, must be having very high FC, and she's in high risk of OHSS.
So the three important parameters are one is to have an antagonist protocol, and to have an agonist trigger, and freeze-all policy. To add to it, we can test for the LH levels at baseline. If it is more than 8, I would give an antac for 3 days just to decrease the LH so that the FSH response is better if we bring the LH below 8, if possible. And the next is to have a very low dose of FSH, and these are some important points to be considered.
No, I would just like to add over here, all these patients who have an AMH value of more than 8 are poor responders in the group of PCOS women. So if you have an AMH between 3.1 and you have and between 8, then these are basically hyper responders, and therefore you should start. So if you look at this group who has an AMH value of more than 8, and especially this one having more than 33, you will see that they are poor responders in the PCOS group. And therefore, you gradually need to you should use a low dose protocol wherein you increase, do the increments in 5 to 7 days. And many a time, it's just like walking on a tightrope, and a stage comes when you just, they don't grow, and suddenly then they start growing once you increase the dose. So you have to be very careful. So these patients, basically, it's best to go for freeze-all. And you have to gradually increase, and you have to counsel the patient that you're going to take a longer time for stimulation as compared to other patients, because we cannot start with a higher dose right from the beginning. So it is basically important to remember that they're poor responders in the PCOS group, having an AMH of 33. Can't hear. Anu.
Yeah,
Ma'am, is there a role of any pre-treatment in these type of patients?
Yeah, usually nowadays there's no use of any pre-treatment, but because it has been said when you're using an antagonist protocol, and if you give combined oral contraceptive pills, this might basically decrease the pregnancy rates and increase the gonadotropin usage. You can give probably norethistérone, or you can give estrogen only for a period of 8 to 10 days before you start, and or you can use as she said about the LH levels, but it is usually seen that these are tonic LH levels, and really whatever you give, it does not make a difference, because they are not the ones which are responsible for activation of the receptors and therefore having its action. So it really, because there's a new theory which is coming up, it says that it really does not make a difference whether you reduce your LH levels or you don't reduce your LH levels. But if you still want, you can use norethistérone for 8 to 10 days, or you can use Proganova for 8 to 10 days in the previous cycle. But it's best not to use oral contraceptive pills.
Okay. Thank you, ma'am.
Thank you so much, Dr. Anupama, for that beautiful session.
Thank you, ma'am.
So, thank you. Dr. Fessy, are you here? Dr. Fessy? Okay, so we are going to start our much-awaited panel discussion on optimizing controlled ovarian stimulation for ART in PCOS patients. And our moderator is Dr. Kundan Ignal. Yeah, please show his CV, Dr. Kundan's CV. Yeah, Dr. Kundan is HOD, Vishraj IVF Center, Pune. He's chairperson EMOX Endocrinology Committee, chairperson Infertility Committee, FOXY 2020 to 23. He's managing council member ISAR. He's Director, Nirmiti Clinic, Center for Assisted Reproduction and Endoscopy, Pune. Vice President, POX, Founder Treasurer, Maharashtra Chapter of ISAR 2011 to 2014. And he has presented various research papers and presented first time research at 6th COGI World Congress at Vietnam on use of GCSF. So welcome, Dr. Kundan. So I would like to invite our panelists. Dr. Kundan, please.
I think it is our proud privilege to have the immediate past Foxy Infertility Committee Chairperson Kundan, who is very young and vibrant, but my good old friend. That's what I want to describe him. So he is always vibrant, as told by the Dr. Ashabak. I think he will make the panel very, very interesting as usual. Over to you, Kundan.
All right. So unfortunately, my video is I'm somehow not able to. It's on, but I can't. I'm not able to seen on that video. But I hope my voice is loud and clear to you.
So audible.
Yeah.
Are you through the laptop or the?
Yeah. Through the laptop.
Is there any screen? Small this thing for the camera. You see,
it was there. Only my video is not seen. I don't know what is wrong with the settings, but it was seen. I'm just trying that since half an hour. Somehow it is not showing my video. But anyway, I can.
Never mind. You are very much audible, so you can go ahead. No
okay, so let me invite my panelist. First is Dr. Ritika Gupta. I think she's from Rajasthan, and she has been silver medal award in her IFS fellowship. Been awarded for best oral paper presentation in Fertivision 2019, and also at AIMS Jodhpur in reproduction medicine update. Even she has more paper awards at Almarcon and Rajasthan, and her field of interest is infertility and high risk. So welcome, Ritika. She's from Alwar and Rajasthan. Then I think Dr. Achal Garg was supposed to join, but she's not joining today. So maybe next, Dr. Shivali Tripathi. Yes, I think she's from Varanasi, and she's a chief fertility consultant at Apollo Fertility Varanasi, and past consultant gynecologist and IVF specialist at Indira IVF at Varanasi. She has many acclaim awards for her academic work. So welcome, Dr. Shivali from Varanasi. Then we have Dr. Nupur. Dr. Nupur is basically from she's from New Delhi. She has finished her 23rd MAMC postgraduate advanced life support course, and also certificate for Purohit technique vaginal hysterectomy by electrosurgery in 2014. She's basically fellow in minimal access surgery. I think welcome, Dr. Nupur. Then we have Dr. Shruti Mane. She's IVF consultant at Motherhood Hospital in Navi Mumbai. And she's also IVA trained cosmetic gynecologist. And at her achievements, she has won some few best paper and poster awards at Bombay Medical Congress as well as Navi Mumbai OBGYN Society. And she has a study of oral labetalol in mild to moderate preeclampsia. And also she has presented comparison of outcomes of IVF cycles after fresh and frozen thought embryo transfer. So welcome, Dr. Shruti. Then Dr. Pratibha. Dr. Tamil, I think we can hear you very loudly. Dr. Pratibha Singh, she's from Varanasi again, and she's a consultant at Nova IVF Hospital in Varanasi. She has more than 8 years experience in reproductive medicine, and she believes in ethical and evidence-based treatment for her patients. So welcome, Dr. Pratibha. She's also fellow in reproductive medicine. Dr. Tamilarasi Arun Kumar, she's basically trained in advanced obstetric ultrasound and Doppler. She has many awards in her credit. So distinction in anatomy, pathology, medicine during MBBS, third prize in inter-college quiz, and she has many paper presentation at AISOG, ACOG, and OGSSI. So welcome, Dr. Tamilarasi. Then we have Dr. Swati Gupta. She's trained and fellow in Foxy certified IVF training from Gangaram Hospital, New Delhi. She also trained from Foxy certified ultrasound and laparoscopy at Karl Stoss laparoscopy training, and she has finished her 2-year infertility and IVF fellowship from Sunflower Women's Hospital, Ahmedabad. She is right now working at Ashirwad Infertility and IVF Clinic in Lucknow. So welcome, Dr. Swati. So I hope all of them are present. If any of them are not present, let me know. So we will start with our presentation. Let me share my panel discussion screen presentation. And yes, I think we are going to uh, discuss today about optimizing the controlled ovarian stimulation for ART in PCOS patient. Now, first of all, friends, and to my panelists here, we are discussing about optimizing, means how best we can offer her protocols of controlled ovarian stimulation. And this panel is totally limited for IVF treatment, not for IUI. For the IUI treatment, our previous speakers has given us quite a significant light on important strategies, but probably those strategies might change when it comes to IVF. So our discussion should be limited to the IVF only. So these are my panelists and friends. We are here to add what we can, we can add to the life, not to get what we can from life. So we have to do something which will add value rather than just all the time take it from the life. And that's what is very important message I want to give to all. We know it is a commonest endocrine disorder for women in their reproductive years, and it was described by Steen Leventhal in 1935. And great debate still exists about its definition pathogenesis, though we do have certain criteria for its diagnosis. But because of its complexity of pathogenesis and pathophysiology and phenotypes, which we have seen in Dr. Madhuri's presentation, and the way they respond to your treatments in different age group as well as during reproductive protocols, I think we really cannot have a actual definition of PCOS for any particular woman. And some women, they have a genetic or environmental predisposition to PCOS, but they do not demonstrate all the features of PCOS. And this is what is important, and that's why make them variable, and we have to classify our patients. But I think Rotterdam criteria in 2003 has given us a very good criteria where there is not too many parameters to diagnose such patient. Quickly, any of two of these criteria, we can say PCOS, that is oligo or anovulatory cycles, clinical biochemical evidence of hyperandrogenism, and ultrasound picture showing polycystic ovarian pattern. So with this, let's understand about IVF role of IVF in PCOS. So our guidelines in 2023, it was very, very clear that if there is an absence of absolute indication for IVF, IVF should be offered to the women who are having PCOS and anovulatory, only if your first and second line ovulation induction therapies have failed. So IVF generally, unless until if there is no indication for clear-cut indication for IVF, never comes as a first or second step. It comes after your first and second line fails. And we know in such patients, being them as a hyper responders, IVF is associated with increased risk of OHSS. And yes, it can be prevented by using GnRH agonist as a trigger and freeze-all strategy. So if you look at the algorithm chart for any patient who is PCOS and having infertility, IVF comes as a third line medical treatment. Now, we must understand that some physiological point, which is very important for such patients, that the impact of insulin resistance in the ovarian response to exogenous gonadotropin. So the incidence of OHSS is significantly higher in the hyperinsulinemic patient, and this is because of the development of larger number of immature follicles in the cohort. So during stimulation, the higher E2 to androgen ratio suggests the presence of greater aromatization activity in hyperinsulinemic patients. And that's why we have to identify those patients who are hyperinsulinemic. They are going to be more prone for ovarian hyperstimulation. So we will begin with our discussion about the strategies. So because it is only we have to focus on ovarian stimulation. Dr. Ritika, we will start from you. that is there any role of insulin sensitizer? See, Dr. Madhuri just thrown a light that it increases the live birth rate, but when it comes to IVF, does it really help? So, is there any role of insulin sensitizers in PCOS before IVF? Dr. Ritika.
Yes, sir. We can add insulin sensitizer like metformin in IVF patient. If especially if the patient is obese and they have a deranged OGTT, so we can add metformin. And in few recent studies also suggest metformin has a role in decreasing the risk of OHSS also. A very few studies are suggested.
Right. So one of the very important points, as you mentioned, is that yes, OHSS prevention is very, very important. And I think uh, just we understood that hyperinsulin patients are more prone for OHSS. And if we add insulin sensitizers, they do reduce chances of ovarian hyperstimulation syndrome. But as our Dr. Anupama actually thrown a light that the OHSS only can be triggered with the role with the if we are giving SCG as a trigger. But if it is an elective plan for elective freeze-all strategy and frozen embryo transfer, there's very less chances of OHSS. So, Ritika, I want to know again from you if your approach changes if it is freeze-all strategy for your patient. So,
I would still add metformin if the patient is obese and has a deranged OGTT. In that case, also I would like to add metformin in the IVF protocol.
Right. Now, suppose your GTT says that it is only insulin resistant but not diabetes. Will you like to still add insulin sensitizers to this patient?
Yes, sir. Yes, sir.
Okay. So we took an opinion from Dr. Ritika, but I need to have any other panelist like Dr. Shivali. Can you tell me what is your own opinion about giving insulin sensitizers before IVF to these patients?
Sir, I would like to be agree with Dr. Ritika. If the OGTT is deranged, either it is deranged or if the female is at higher side of BMI, then only it has to be added.
Okay. And we know that, Shivali, that it is ideally to be given into 1.5 gram per day. I mean, that is 500 milligram 3 times a day. What do you think, that 500 milligram twice a day is sufficient or 3 times a day sufficient?
Sir, usually we start with lower doses. Like I will start with 500 at the bedtime. And in 5 to 7 days, we'll be going to 500 VD. And slowly, if she tolerates that, then we can escalate the dose till 2 grams a day.
Okay. So, any time do you feel that there is the advantage of giving 500 milligram 3 times a day instead of twice a day?
Sir, it depends on patient's BMI. If it is, if she's towards higher side, then up to 2 gram we can go.
Up to 2 gram we can go. Yes. Okay. Let's go to Dr. Nupur. Dr. Nupur, do you agree with all this discussion? And I have one question for Dr. Nupur is that only metformin you want to give, or you want to give no metformin, but I want to give myoinositol. Do you agree with this notion, Dr. Nupur? Is she there? Okay. Then Dr. Shruti.
Hello, sir. Yeah, yes, sir. So insulin sensitizers as metformin or myoinositol. So there's a basically in practice, if there's a obese woman with insulin resistance, and like Dr. Ritika said, if there's a deranged OGDT, we can add metformin. But if we go according to the data which we have, Cochrane has said that if a patient requires a agonist cycle in cases of PCOS patients, then you can start that patient on metformin. But if the patient is going for an antagonist cycle, there's no role of metformin as it's going to reduce the live birth rates.
Okay, I think that's a very valid point, Dr. Shruti, with this kind of protocol selection and then using a insulin sensitizer, because it has been seen in the literature that with these two different down regulation protocols, insulin sensitizers, they really have a different effect when it comes to. Dr. Pratibha, if you're there, Dr. Pratibha, have you used any time both the drugs as insulin sensitizers, metformin as well as? Now, please, we are discussing about IVF, not we are discussing about IUI. So combination, giving metformin along with myoinositol.
So I have used both as a combination also.
Okay. So, what is your preference, Pratibha? Your opinion
So
in your
my preference
practice?
is combination.
Combination.
Yes.
Okay. And what kind of advantage do you feel that using a combination instead of only
So
one insulin?
bio-inositol also decreases the insulin resistance also, and the level of testosterone also means the biochemical parameters are decreased with both the combinations.
Okay, let's see what evidence has to say. And recent say in Cochrane's review in 2020, and this is very updated review about metformin and insulin sensitizers, and they say and they concluded that if a metformin is compared versus placebo or no treatment before IVF or ICSI treatment in women with PCOS, they found no conclusive evidence that metformin improves live birth rate. So when it comes to live birth rate, probably it's not going to help. Now, they do find that long GnRH agonist protocol, they found that it is very uncertain whether metformin really improves live birth rate, but it may increase the clinical pregnancy rate. And when it comes to antagonist protocol, probably they, in fact, found very reverse that it reduces the live birth rate, and they are not uncertain about effect of metformin on clinical pregnancy rate. So probably when it comes to antagonist protocol, they did not find any kind of benefit in terms of achieving a cardiac activity at 7 weeks or live birth rate. But when it comes to agonist protocol, they did find that clinical pregnancy rate is better with the metformin. And yes, we discussed high incidence of side effects are there, and also reduce the incidence of OHSS. And there absolutely evidence is unclear about effect of metformin on miscarriage rate per woman. So that's what has been since 2012. We are thinking
Sorry to
that there is
interrupt,
no need.
Dr. Kundan. But the thing is that why
Yes,
would anybody be going for agonist protocol in a PCOS patient?
agree with you. But there are people, this we will discuss it at the end of the panel discussion, that there is a possibility where you may not even like to do a frozen embryo transfer, and you may like to go for a fresh
Right.
transfer. And you may use it in a certain scenarios where you have a quite a asynchrony of growth, and you want some synchronous growth. So you can still use long GnRH agonist protocol, though it is maybe I will say 5 or 10% of patient. But we have to understand that according to the protocol, the effect of metformin do changes. And the review is very clear that after the pregnancy is achieved, probably continuing the metformin is actually not helping us to reduce miscarriage, or kind of to achieve a live birth rate. So that's a very important message which I wanted to give with the updated review. Now, there was another review and meta-analysis in 2022, which was regarding the inositol, metformin, and the combination. And what they realized that the clinical pregnancy rate in comparison of metformin and placebo, almost in 1,312 patients, they were higher in metformin group. OHSS was less in metformin, but live birth rate were not statistically significant. Ms. Vikas Singh, please, I request audience to be silent, please. Vikas Singh, please mute yourself, please. Okay. And when they've compared about inositol with no treatment, and there was no difference in clinical pregnancy rate. So possibly the conclusion which we can draw, that maybe metformin will help us to reduce insulin resistance and have a better ovarian response. But as soon as the pregnancy is achieved, probably there is no role of continuing metformin ahead of pregnancy test is positive. Okay. Now, there was another kind of a review in 2021 about myoinositol, which said that yes, it does help in regularization of menstruation. That is, it improves the ovulation rate, it improves the oocyte and embryo quality. But we do not have proper studies, only few small size studies. They are not even randomized control trials. So we need large multicenter good evidence to suggest that yes, it increases clinical pregnancy and live birth rate. So it's a big no for inositol when it comes to IVF in PCO patients. One more paper, which was very recent, 2022, and it was compared that if we give minoxidil, now please remember, we used to always give 550 milligram twice a day minoxidil for all these patients. Now, this particular group has given us a double-blind randomized control trial where minoxidil was given 2 gram twice daily. Means what? Per day it is 4 gram. It's a quite a high dose. Okay. And that was compared with metformin, which was per day 1500 milligram. And what they realized, these are all PCOS patients undergoing IVF. It was a double-blind RCT. And they said that if you give minoxidil in such a group or such a dose, then clinical pregnancy rate as well as your cumulative pregnancy rate during FET is all significantly high, and it is in favor of minoxidil than your metformin. And we know that minoxidil has got a lesser side effects and metformin has got gastric intolerance. So even if you look at the spontaneous conception, when you put the patients on minoxidil on such group, 26%, again significantly higher, they had a spontaneous conception, and incidence of OHSS was again non-significantly but lower in minoxidil group. And they found that there was no difference in fertilization rate and as well as cleavage rate and number of good grade embryos when you use minoxidil in such group. So there is no affection on the, there is no negative impact on fertilization, cleavage, and good grade embryo rate, but having a better outcome. So this was one paper in 22, which I wanted to highlight. So that, remember, 2 gram twice daily. Probably this was only one study. Again, if you look at the size, it is only 52 patients. We need a larger size to prove this notion. Now, coming to Dr. Tamilarasi, can you hear? Are you there? Okay. So Dr. Pratibha did say that, yes, she wants to use the metformin and minoxidil combination. Now, if you look at the evidence about this particular, there are only 2 randomized controlled trials. And this 2022 review actually studied those in detail, and they found that no, those are not the eligible RCTs for meta-analysis because there is a lot of heterogeneity. So if you look at real literature, okay, experience probably by Pratibha Singh and other, you may find is better. But when it comes to IVF, in PCOS patient, probably we do not have sufficient evidence about using a combination that it does help to improve the outcome. So, Dr. Swati Gupta, are you there?
Yes.
Yeah. Swati, I want to ask you one question. What is the cutoff for oocyte numbers after which you will say, I want to do a freeze-all strategy in PCO patient? Now you have started a stimulation, but when you retrieve the oocytes, you have a different numbers or you have a different ovarian response to your gonadotropin. So what will be the cutoff? You will say, no, after this numbers, I will go for freeze-all.
If I retrieve more than 15 eggs from each ovary, so in that case, I will go for freeze-all strategy. And if
Perfect.
the E2 level on the day of trigger was more than 3,500, so in
Right.
that case also I will freeze-all strategy I will use.
Yes, I think you are absolutely right. And if you look at the cumulative live birth rate, okay, especially in this patient who has got more than 15 oocytes, there in freeze-all group, they will have a more better cumulative live birth rate if their first embryo transfer cycle has failed. And the incidence of OHSS was also significantly lower. So sometimes we start the stimulation with the intention that I want to do an adequate stimulation, probably maybe just 10, 12 oocytes, and that's it, and want to do a fresh transfer, but they respond very differently. And then you have to go for your this kind of effect. And we know that we have evidence that only high responders, if you have more than 15 oocytes, then clinical pregnancy rate and live birth rate is more in favor of frozen embryo transfer than doing a fresh embryo transfer. But this evidence completely changes if you have a low responder where we have got less than 5 oocytes. In fact, with a frozen embryo transfer, clinical pregnancy rate and live birth rate are significantly less in comparison with fresh embryo. So yes, as you rightly said, I think once you have more than 15 oocytes, probably you will like to go for frozen embryo transfer cycle. We know the principle of ovarian stimulation. We want an adequate number of good quality oocytes. If they are more than adequate numbers, then we are still happy because our cumulative live birth rate is going to be better. And second is to prevent the LS surge and to prevent the OHSS. So we have during IVF stimulation 3 steps: ovarian stimulation, down regulation, and ovarian trigger. So my questions coming back to Ritika, this question is that what about AMH levels? Okay, now we know that we do AMH level surely for poor responders. But in hyper responders, as Dr. Madhuri has already pointed out, if it is more than 8, probably they respond very differently. And between 3.5 to 8, we have a higher chances of ovarian hyperstimulation. But in your practice, Ritika, do you do regularly AMH level before IVF, or you just diagnose PCOS on your Rotterdam criteria and you don't need AMH levels for your deciding the dose of gonadotropins?
For IVF patient, I routinely do AMH level for all the patients before starting stimulation. So it's
Anybody from panelists who differ with her opinion that it really helps you in deciding the protocol and dose of gonadotropins? Dr. Shivali, Dr. Nupur, or all of you do AMH levels?
Actually, PCOS.
Yes.
PCOS patient is very tricky for the stimulation. So AMH definitely will guide us while we are doing stimulation and in deciding the dose also. But along with AMH, the ovarian morphology, what is the number of the follicle, what is their appearance and how they are arranged in the ovary, what is the volume of echogenic stroma, this all will guide in stimulation. So AMH is definitely very necessary in my point of view before starting the stimulation.
What about Shivali? What's your opinion in your practice?
Yes, sir, we routinely do AMH before deciding the dose. And as Dr. Swati rightly said, we also see the echogenicity of the stroma to understand whether the patient might land up into OHSS. So definitely we do AMH.
So one of the way or advantage of doing AMH is, see, AMH is best predictor for ovarian response, right? So probably with the AMH levels, you might be able to predict chances of ovarian hyperstimulation for all our PCO patients in IVF, right? But is it really helpful, Swati, that you can actually decide the dose of gonadotropins on AMH levels? And how do you decide?
No, sir.
No, on AMH level, we don't decide the dose of gonadotropin. Normally, we decide the dose according to the patient age, BMI, and what was the previous, if she was previously stimulated for IUI cycle or any other cycle previously. So by that also, we can get the right dose. And these are the main criteria for, and the morphology, the look of the ovary during stimulation. So all these factors, but AMH will also help us to guide the patient, to counsel the patient what is going to happen during the stimulation. For counseling purpose, AMH also is necessary.
I think your point is right, but I have one argument point with Dr. Swati. Can you throw your own opinion? Say, for example, if you are looking at on transvaginal scan and you see there are 18 antral follicles on the right and 22 antral follicles on the left. Okay. Now you know that the antral follicular count is in the range of 40. If I start a dose of say 300 HMG for this patient, she is going to give me more than 15 oocytes with 300 IU because her basic cohort is good. Okay. Now, in such scenario, if you do a AMH, okay, and for example, your AMH turns up as 5, what exactly impacts on your counseling points?
Definitely AMH is not that much high, but it's in the PCOS range. So I will not start with that much high dose. I will start with lower dose and I will do the counseling in that way that this stimulation will last longer, because I am starting a lower dose and I will closely monitor your cycle maybe every 2 or 3 days. And after this close monitoring, and I will try to prevent this OHSS. So definitely in this way.
So, okay, Shivali, the question comes to you. Can you unmute yourself? So, Dr. Swati said she has certain points during controlled ovarian stimulation time period that, okay, I will use with a low dose. Probably I will push it for a longer time of duration, but have a lesser stimulation. But for example, you know that even if she gives you 30 follicles in her stimulation cohort, I know I'm never going to give her SCG because she's hyper-responders. I know her since beginning. So I'm going to use agonist as a trigger. Still AMH is going to help me.
So many a times in our practice, what we see is
that the females who are having high AMH, they are mostly, they give us oocytes, but the oocyte quality is compromised. Many a times poor oocytes are seen. So if AMH is high, we at least can counsel the patient and can mentally prepare ourselves that in spite of good number of follicles and good number of oocytes, we might not get that many embryos. So this way AMH can help us.
Okay. So, Shruti, what is your opinion about AMH? I want to.
So, as we know, high AMH is known to cause inhibition of the aromatase activity. So, the androgen to estrogen conversion is going to be less, and the androgens are going to be high in these cases. And also, it is known to cause FSH resistance in these kind of cases where the AMH is high. So, depending on the phenotype, it will help us to know what dose of FSH you need to start in these kind of patients.
Can you give me an example, Shruti, for all audience benefits, that how you would have think about having AMH 5, having same patient 18 and 22 antral follicles, and she's non-androgenic. Now what?
So non-androgenic, okay. So basically, if the cohort is 40, so I might start her with an FSH, rec FSH, because rec FSH, if you go to the literature again, it is shown to have good number of M2 sites. So I would start her with a rec FSH dose of, depending on her BMI, of course. So if her BMI is less than 30, I'd start her on somewhere between 225 to 300. And then I would either step down or step up depending on the response on day 6 of a cycle, sir.
Okay. So I think all my panelists have thrown a fantastic light on AMH levels. Now we need to understand the literature. That's just a conclusion message for my audience. Yes, it's not like that AMH is not necessary for any patient of PCOS undergoing IVF, or it has to be done for all the patients. Now you have to judge it according to your antral follicular count and the response or previous response. So AMH only gives you idea about how will be the ovarian response. Okay, it will never predict your quality of those sites. It will never predict the chances of pregnancy, or it will never predict the chances of live birth also. So AMH level has to be little individualized. AFC is something which you will always use in PCO patient when they are undergoing IVF about deciding the dose. Only in patients who are really classical PCO, where you have more than 25 antral follicles in each ovary, where your antral follicle count is beyond 50, you will like to check the AMH levels, because if the AMH levels are beyond 8, then there is a little chance, there is quite a good percentage of chance that this patient is going to behave like a poor responder. Okay, so only to identify this group of patients, probably AMH can be applied. Now, pushing for the next question, I think Dr. Tamila Rasi, is she there? She's there, I guess. Dr. Tamila? Are you there, Dr. Tamila? Okay. So, okay, Dr. Pratibha Singh, the question is to you now. Which protocol is your best for PCOS patient? Agonist or antagonist? Very simple question.
Antac protocol any day.
Great. So for antac protocol, you are for, obviously it is for, you can use as a GnRH agonist as a trigger and go for a freeze-all strategy. Right. Now, we have seen this for all the, there are good studies. 2016, it was a randomized control trial, and it did say that antagonist protocol, we have this lower rate of complications because of the agonist trigger, and it's the best thing. And there are no, there is no significant difference between your pregnancy, implantation rate and miscarriage rate in both the protocols. But OHSS group, OHSS rate is significantly low, especially in antagonist. And also with agonist, there are more days of stimulation is required, more number of gonadotropins is required. So how will you use GnRH antagonist, Ritika, for your PCO patients? How? Means there are two protocols. Yeah, please.
I'll go with the flexible GnRH antagonist protocol. So starting with the day 2 of stimulation and checking after 4 days of stimulation, then again checking on the 6th day. And if the bleeding follicle is 14 mm, I'll start the antagonist for the next few days.
Anybody from the panel? Okay. Anybody from panel? Shivali, Nupur, Shruti, Pratibha. Are you anybody from panel who is using fixed protocol like day 5? You start antagonist for any PCO patients. Anybody who is using fixed protocol? Give your opinion. Dr. Shruti, what is your own opinion? Flexible or fixed GnRH antagonist protocol?
So I usually practice a flexible GnRH antagonist.
Flexible GnRH.
Yes, yes.
What is the disadvantage of following fixed antagonist protocol?
So, if you use a fixed protocol, for example, on day 5, if I add antagonist and the cohort is not selected, there is a risk that I will end up with less oocytes or no oocytes.
You'll end up in having no sites.
Yes.
Okay. Okay. Now, suppose I give a different scenario, Dr. Shivali. This is for you. Like, suppose you have started, say, 300 milligram. Okay, no, that's too high. 225 HMG on for PCO patients who's got parental follicular count of almost 35. And day 5, you realize that only 5 follicles are above 10 to 11 millimeter size, and rest all follicles are 7 to 8 millimeters only. Now, in this scenario, if you don't start antagonist, what might happen? Do you think that not starting antagonist will have a disadvantage to Shivali? Shivali?
Sir, I'll be waiting for one more day. I will not add that day.
Great. So I think we need to understand that what happens after antagonist is basically it's a pituitary downregulation. So there is a sudden blockage for FSH and LH. So there is no FSH endogenously and there is no LH. So the first of all, you will come across with certain PCO patients that they do have a very high LH, and that high LH is actually not allowing certain follicles to grow. And that's what you get this kind of responses in this patient. Now let's see what evidence says. So a 209 patient received flexible antagonist protocol and 225 patients received conventional fixed antagonist protocol where antagonist was started either on day 5 or day 6, irrespective of the follicle. And this study, which was again a retrospective study, they found that both the protocols are as effective as, for each other. You use fixed or flexible, okay, in antagonist protocol for most of the patients with having a good reserve. So probably it may not even have an advantage. So all my panelists are right that according to the response, they will decide about when to add antagonists, especially when the follicles are 14. Now, only one scenario which I gave you where you have few follicles which are beyond dominant size and rest of the other follicles are very smaller. Now, if you add antagonist and little earlier, like day 5 in this scenario, so your whatever gonadotropins doses comes, the smaller follicles will consume the larger amount of gonadotropins and the larger follicles will consume the smaller amount of gonadotropins. So in only this scenario, if you add a antagonist little early, you will see that your lower size or smaller size follicles, they grow faster than your larger size follicles. So only one scenario where you will like to add fixed antagonist protocol on day 5 or day 6 is only such kind of response. So for all audience purpose, this is how the antagonist protocol is planned. You give it for 4 days. If it is a fixed protocol, you add antagonist on 5th day, or you continue your HMG doses according to the response. And once the follicles are 13, 14 millimeter, you can add antagonist. Now, next question is to Dr. Swati Gupta. Is there any role of OC pills prior to stimulation cycle in GnRH antagonist protocol in PCOS patient? As Dr. Madhuri also and somebody asked question that in a asynchronous growth, what you will give, and OC pills can one of the option. But as a protocol, every PCOS patient once you are diagnosed, undergoing IVF, will you give OC pills, Dr. Swati?
Only on these patients who are having the irregular cycle, asynchronous ovarian growth, AFC. So in that cases, only I will use the OCPs. Otherwise, if the cycles are not irregular, so I don't use, because in that case, if I will stimulate with gonadotropin, then the dose of the gonadotropin I have to give in a bit higher dose for the stimulation if I have downregulated with giving OC pills in previous cycle. So not in all patients.
I think she's absolutely right. Now, this was way back in 2006 when it was from a very well-read group of authors of this paper. They did a randomized control trial in 2006, and they documented that if you give OC pills, there's a significant higher chances of miscarriage rate when you are giving for any patient who is undergoing IVF protocol. But the recent evidence in 2024, which is like it is still in the printing phase, it was a randomized control trial where PCO patients received OC pills, which were ethinyl estradiol and drospirenone for 21 days prior to ovarian stimulation for IVF, and it was compared with the group who did not receive. And they found there is no difference in terms of number of good quality embryos, blastocyst rate, implantation rate, clinical pregnancy rate, live birth rate, cumulative live birth rate. So giving OC pills probably is not increasing our any kind of parameters. So it is very clear that for any patient who is PCO and undergoing antagonist protocol, you don't need to think of giving OC pills for this patient routinely. So that's a very clear-cut message. Dr. Shivali, what should be the starting dose of gonadotropins during ovarian stimulation in IVF? What is your usual dose? Is it 150? I'm talking about HMG. So is it 150? It is 225, or you will still go for 330? 300. What do you do, Shivali? How do you decide your gonadotropins dose?
Sir, in Indian scenarios, the lowest dose which we start with is 225, and maximum is 300. We don't go beyond that.
Okay, Dr. Ritika, anytime do you think that 150 is also enough for such patients?
Sir, we usually start with the 225 and maybe increasing to the 300 also if the BMI is high, patient is obese. So we go up to the 300, but mostly 225, not below 225.
So I think, as rightly said by both of them, probably when we are planning a antagonist cycle and agonistic and freeze-all cycle, even if you have a little more than adequate response, we are still happy.
Sir, I would also like to add, we always add the latrose with the gonadotropin stimulation, the IVF cycles.
Okay, that is to reduce the estrogen levels. That's what you mean to say?
Yeah, that will help in the reduce the estrogen level, and that will help in the reducing the dose of gonadotropin also. So better stimulation, better ovarian response.
That's fair enough. That's fair enough. That's quite a good rationale for using this. Okay, Dr. Shruti, this question is for you. Any role of pre-treatment like estrogen, progesterone routinely before ovarian stimulation in IVF in PCOS patient? Do you give routinely just to avoid asynchrony of the follicular growth?
So if this patient is having irregular cycles, I would give her, withdrawal with progesterone. But routinely, I haven't been using pre-treatment with estrogen in these kind of scenarios.
Right. So, Dr. Swati, which group of patients you use majorly for pre-treatment as estrogen as a pre-treatment?
Estrogen I am not using for pre-treatment. Only either I give the OC pill or this progesterone. I'm in my practice, I'm not using estrogen. Only the asynchronous growth is there or cycles are irregular. So in these cases,
I think that's what I wanted from you, Dr. Swati, that see the majorly, if you look at the incidence of asynchronous follicular growth, you will come across this kind of response majorly in poor responders, that over reserve, and sometimes in some normal responders. But generally, in a hyper responders, you may not see those kind of asynchronous follicular growth where you have more than 3.5 millimeter difference in the follicular sizes. That is the larger size and a smaller size cohort. So usually it has been very less extensively studied in PCOS patient, especially estrogen and progesterone as a pre-treatment. I did not come across any single study who has compared estrogen progesterone as a pre-treatment in PCO patient. Most of the studies are done for normal responders and majorly for poor responders. So probably big no for as a pre-treatment on a regular basis for such patients. Dr. Pratibha, what do you feel about which type of gonadotropins is best one for PCO? Because one of the panelists did say that I want to use recombinant FSH for my PCO patient because they give you more probably more better ovarian response. So what is your opinion, Dr. Pratibha?
Sir, in my practice, I am using more of HMG.
Yes, and any benefit of HMG over recombinant FSH?
So literature says the benefit of both the gonadotropins are same. The recombinant FSH is more costlier. So we are using more of the humox cycles. That is what.
So
So if
PCO
you
patients have
Yes,
PCO
please.
patients have endogenous LH deficiency. So if we can add LH, like if we are using HMG from the day 2, then it will be giving better response as per the literature.
Yeah, but the PCO patients do have a higher LH. Why they should have an endogenous LH deficiency? So
They
this
have
was a
high LH, but
Ah,
the sensitivity to LH is low.
okay. So this was a mega set HR trial. I think all of us are very, very clear about this trial, largest multi-central trial. And it was comparing in hyper responders patients only, highly purified HMG and FSH. And specifically, if you look at the chances of hyper response, it is more with recombinant FSH because it gives you more response. But if you compare the outcomes like ongoing pregnancy rate, they are all same. You use HMG, you use recombinant FSH, but especially the early pregnancy loss, that is the miscarriage rate, is the difference between miscarriage rate between HMG and recombinant FSH is by 8% almost, which is lowest in HMG. And we know that we need kind of a good uh, cytoplasmic maturation of oocytes, and that's for that reason we need a LH. So giving HMG is probably has a benefit in two terms. It reduces the chances of ovarian hyperstimulation and it reduces the miscarriage rate non-significantly, but definitely lower in with when you use HMG. Now, how many oocytes are sufficient in PCOS when she can give you more? So, what do you do, Ritika? She can give me 30 oocytes, 40 oocytes. I will be still happy. I have prevented her ovarian hyperstimulation, but I might have 8 to 10 blastocysts in my kitty where I can use them for first pregnancy, second pregnancy. So what do you feel that, Ritika, how much is enough?
I think 15 to 25 oocytes are enough for us to get a maximum number of blastocysts for the patient. And in that way, we can prevent the OHSS also and giving the maximum benefit to the patient. So 15 to
Shruti,
25 oocytes.
Yeah, Shruti, what's your opinion in this regarding?
So with PCOS, I would like to say the fertilization rates are low with PCOS oocytes. So I would say the more the better. But
More the better, okay.
yeah.
There are two pictures which we have seen. Sometimes we do get 35, 40 oocytes from these patients, and still we do not have that kind of yield in terms of good quality blastocysts for freezing. So sometimes even getting 35, 40, we may get at the end of it 4 or 5 good blastocysts. So remember the PCO patient who's got that follicular cohort available, many of the follicles which are lying down there for a longer time and they are exposed to a lot of androgens, they're exposed to high LH, their quality of oocytes is poor, so they do perform very poorly. So, what Ratika also said that, more than 15, maybe up to 25 is okay. So if you look at the evidence has studied this. It was little long time back, 7-8 years back, where they studied that, okay, 1 2 3 4 to 9 10 to 15, more than 15, but definitely more than 15, because if you have more than 15 oocytes, then there is cumulative live birth rate significantly increases. So at least not less than 15. We don't know 25 is enough, 30 is enough, 35 enough, but definitely at least 15 is something what we really expect. It's a good number for such patient. And this is all I am talking about PCO patients. Coming to ovulation trigger in hyper responders, I think I don't need to ask this question because it has been very clear that hyper responders, to prevent OHSS, we have to give GnRH agonist. Only one question regarding this, and that question goes to Shivali. Shivali, what dose of GnRH agonist as a best trigger? If you are using leuprolide acetate, are you happy with 1 milligram? Are you happy with 2 milligram? Or you feel that no, it was too much response, so 3 milligram is better? If you are using a decapeptyl triptorelin, so 0.1 is fine, 0.2 is fine, or 0.3 is fine. How do you decide, Shivali?
So we are using decapeptyl 0.2 mg.
0.2 mg for all the patients.
Yes, or for all.
Pratibha, do you use higher dose if you have a too much response?
So more than 7, if the weight is more than 70 kg also, then I use 0.3 mg.
0.3 for more than 70 kg.
Yes.
Okay. Swati, what is your opinion?
Sir, I have never used 0.3. I have always used 0.2. 0.2
But anytime
decapeptide.
did you
Not
find that
related.
okay. Anytime did you find that, oh, I should have given 0.3, I did not get, I had lots of immature oocytes. Did you come across like such in a scenario?
No, sir.
Never.
No, sir.
Ritika, what is your opinion about 0.2 and 0.3?
Sir, I am using Lupride, not decapeptide.
Okay. So 2
look-
milligram or 3 milligram?
3 milligram.
3 milligram. Okay. Do you anytime found that 2 milligram, I still got a good M2 and
Sir,
M1
in the
ratio?
thin patient, the less obese, in the normal BMI patient, I am using 2 mg, and for the obese patient, 3 mg.
Okay. So friends, I think again, the dose comparison study for GnRH agonists has not been studied yet. Okay. We do not have good literature evidence about whether this 2 milligram is good or 3 milligram is good, whether 0.2 or 0.3. But it has been seen for a good follicular oocyte ratio output. It is definitely proven that if you are using a triptorelin, it is 0.2 is something which is minimum should be given. And if it is luprolide depot, then luprolide acetate, then it is 2 milligram has to be given. We do not have any evidence which says that higher dose is necessary. You get a sufficient LS surge with these kind of doses. Now, Dr. Shruti, if GnRH agonist trigger is given, and if you want to do fresh transfer, what is your rescue step? See what happened. You did you told the patient to take an agonist, and you send the E2 levels which you did not receive today, and next day morning you received, and the response was better. I mean, you were suspecting OHSS, that this response will cause OHSS, but suddenly the E2 levels are only 2500. Now you felt that no, I think I should have given SCG and would have gone for fresh embryo transfer. But now agonist trigger is already given. So what you will do to rescue this step?
So to rescue this, I can give her a microdosing of HCG, 1500 international units.
And will you give this?
So basically, sir, on the day of oocyte retrieval, it can be given, and then I can start her on the LPS, luteal phase support.
Right. So I think one of the way the literature is in favor, what Shruti has correctly said, that you can give at around 35 hours, means as with the agonist trigger, once you have done the oocyte retrieval, immediately after oocyte retrieval at 35 hours, you can give 1500 IU of SCG, which will not allow that early luteal phase defect to happen, and give lots of progesterone from outside so that you can prevent the luteal phase defect. So friends, strength doesn't come from what you can do. It comes from overcoming the things you once thought that you could not. So my question to Shivali, what is better, fresh ET or frozen embryo transfer in PCOS patient? Would you like to always go for freeze all and no fresh transfer, no first fresh, and if it fails then frozen, or I will like to go for fresh ET? What is your preference nowadays?
Sir, more towards FET. Only in rescue situation.
All patients you do FET for hyperresponders?
No, sir, as you said that if on the day of trigger, if we have got E2 levels low, if the patients have given more oocyte, but the quality is not that good, if we are suspecting that we might not be able to freeze the embryos, in those cases, we can plan for fresh transfer. But in patient's benefit, if it is possible, better to do freeze all.
Yes. So I think only one parameter, it's only one parameter which tells us that yes, I must do a freeze all and frozen embryo transfer for all PCO patient, and that is depending on your ovarian response. Whenever you think that there is a higher chance of moderate to severe OHSS, or depends on number of follicles, depending on E2 levels, probably you can, on that response, you can take this decision. Now, instead of antagonist, have you used progesterone prime ovarian stimulation protocol? Any advantage, any disadvantage with progesterone prime?
Sir, in the practice, I am not using progesterone primed ovarian stimulation, But as far as the literature, I know that there's a we can use the PPOS protocol for the PCOS patient. First advantage will be reducing the cost of the IVF cycle, definitely.
Perfect.
And
Okay.
fewer injections maybe. And but I'm not using in practice the PPOS protocol.
Okay, Shivali, have you used progesterone in your practice as a down-regulating agent?
Sir, not yet, but planning to start. Same, the cost.
Then today's webinar is successful in that case. Dr. Shruti, what about your opinion?
So
Have you used?
I'm not.
You have never used.
No.
Pratibha, have you used any time?
No, sir, never.
Swati, have you used any time?
So once I have used this Medrol from day 2 of the cycle.
Okay. What did you
I
find?
have used it. The response was good in that case. And the cost was also decreased. So it was
I
cost
think that
effective.
protocol will be useful if you're using the donor cycle also, because most of the donor cycle we have a good number of follicles, and the cost will also be reduced with if you're using with the donor cycles.
You are very right, absolutely right. But we are talking about PCOS. Okay. So what evidence says, the systematic review is very, very clear that if you use a progesterone prime, it is correlated with very low risk of OHSS, and but the more gonadotropin doses are required. So probably yes, antagonist, you will save on antagonist, but there will be 1 or 2 days more for ovarian stimulation. So cost wise, I don't know how much, but yes, if you look at the egg quality, if you look at the LH levels on the day of trigger, if you look at the pregnancy outcome, there is no difference between PPOS and antagonist. So I think you can use PPOS as a good protocol for all the PCO patient when you are planning ki I am going to do freeze all for all my PCO patients. My plan is to do freeze all. There, yes, PPOS is definitely good. With one disadvantage is only that 1 or 2 days of extra gonadotropin doses is going to be required. So any of my panelists, anybody can take this quickly. Will you believe, following this notion, that adequate stimulation is better, followed by fresh transfer, is better than frozen embryo transfer? That I even used to do it when vitrification and technology was not there. Frozen embryo transfer protocols were not there before 2014, 15. That time we never used to plan freeze all. So that time still we used to do a fresh transfer, and we used to get a good pregnancy rate in PCO patients. So I was happy with that. This was unnecessary that I'm having more oocytes. I'm putting a financial burden of freezing all oocytes. Then I'm also applying thawing charges, and expenses have gone up. So anybody who feels that adequate stimulation, I will love to still follow.
So where cost is a major factor for the patient, I would think that mild stimulation or minimal stimulation, where we use CC plus minimal dose of gonadotropins followed by fresh transfer, can work in those kind of patients.
Right. What about any other? Yes.
Sir, as in the PCO patient, still I would like to get more number of oocytes, more embryo for the freezing purpose also, because if you see the cost, suppose the first cycle doesn't work, and we should have something to frozen, so that we can use in the second cycle. We don't need to go the further stimulation the second cycle. So I would like still the maximum number of the oocytes I can get from the patient, that kind of patient, the PCO patient. If the patient has potential to give us a more number of oocytes, I would like to get those oocytes actually.
Yes, Dr. Swati, what is your opinion? Dr. Pratibha, Dr. Swati, what is your opinion?
Sir, I believe in frozen embryo transfer, not fresh transfer.
Okay, so most of our panelists, they do believe that, yes, I think having little more than 15 oocytes is better.
One observation I just wanted to share. Even if we go very slow, very low, even if we are following very low doses, even then like 1 or 2 patient will land up in OHSS, even with GnRH agonist protocol. So we don't know this. The response is many times very stormy. Like on day 8, day 9, you'll see the smaller follicles growing up, and patient. I have seen a patient in whom I was doing pickup, and the whole bloody fluid was being aspirated. So better, better to, if possible, better to go for FET cycle.
I think, Shivali, you have brought up a very good important point, that it's a very unpredictable ovarian response in PCO patients. So it's better to counsel our patient right from beginning that how we can go ahead with frozen embryo transfer first as a first choice. In case if I have a kind of a suboptimal response where there is a possibility that I can do a fresh transfer, you can always go ahead with the SCG trigger. So I think you guys have thrown a fantastic clear cut messages when it comes to optimization of ovarian stimulation. Now I purposefully did not include how you will plan frozen embryo transfer because this panel was only limited to controlled ovarian stimulation. So we know it is an art which is to be developed over the time period, learning from our own cases, understanding how each patient responds in a different way to your stimulation protocols. But our aim is never changes that we need a good quality, sufficient number of oocytes, and we don't want those complications. And with the help of ovarian reserve predictors, I think we can identify our different categories of patients, use the optimized ovarian stimulation protocol for our PCO patients. And as I said, one size do not fit to everybody. Maybe little individualization is necessary sometimes for optimization. So this is very important and excellent panelist, I think, and their contribution in terms of these questions. Thank you very much, my friends.
Excuse me, sir.
Please.
Sir, I have a question.
Okay.
Have you ever considered the repeating the dose of trigger after 12 hours of first dose?
Okay, you are asking a question to a moderator, which is not allowed, but I am going to answer that. So you said that you have given a trigger of agonist. That's what you said, right?
Yes, sir.
And when you want to, the question was that when you want to repeat 12 hours.
Yes, sir.
Okay, so interesting question, Ritika. So what I do in my practice nowadays that GnRH agonist trigger, sometimes these patients, we don't know their pituitaries, how much LH production is there. So we don't want to have a empty follicle syndrome because sometimes there is no LH surge with your agonist trigger. So the practice which we follow in nowadays to prevent this situation is that we give a agonist trigger and 12 hours later we do send LH levels for all these patients who have taken agonist trigger. If you have LH levels 12 hours from agonist level more than 15, you don't need to worry. You will get oocytes surely. You will get oocyte cumulus complex surely. You will not land them in empty follicle syndrome. But in case that 12 hours value, if it is very less, means it is less than even 10. It is sometimes, if there is no LH surge, you have LH levels are right from 0.5 to 5. So there LH surge has not happened and you have to be careful because in this patient, even giving second dose of agonist probably may not help because she will not respond to your second agonist. There you may have to go with a SCG only with a lower dosage and you have to follow all the therapeutic options to prevent OHSS. You have to manage that. Now, sometime if the ovarian response is too bad, it's too much and your estrogen levels are 6,000, 8,000, 10,000, probably best is not to give anything because you have to abandon the cycle because you cannot give SCG because she will land up in severe OHSS where it becomes a very difficult to manage. Maximum you can just give a tries to repeat agonist and again 12 hours later see. But I will tell you by experience that she will never show you with a second trigger any LH surge because her problem is that her pituitary do not have sufficient LH in pituitary. So generally you follow in all patients that you do a serum LH level 12 hours after your trigger. And then if your LH levels is above 15, you will not land up in empty follicle syndrome. So thank you, panelists. I think those were fantastic discussion from all of you. And I hope I was justified. I justified the panel by asking the right questions. Thank you, Dr. Anu, for inviting me to conduct this panel, and thank you all the panelists for your contributions.
Thank you, sir, for the wonderful panel.
Thank you so much.
Thank you, ma'am.
Thank you, sir. Thank you, Dr. Kundan. It was wonderful panel and all panelists, they were too good. And so I think everybody is going home with so many take-home messages. Thank you. Thanks a lot.
Thanks, Kundan, for conducting an excellent panel.
GnRH agonist, Kundan, you should do LH and progesterone level because even a progesterone level of more than 3 nanograms is an important finding. So if you have a low progesterone level, again, the chances of getting an empty follicle is much higher. So you should do both LH as well as
I do agree. There are papers who have done serum progesterone levels along with LH, but I always feel that to have a good oocyte maturation and release of your complex, you need a LH because that acts on your receptors.
Yeah,
Of
because
course,
in a
it is a
normal
parameter. Yeah.
no, in a normal cycle also, there's always a pre-ovulatory rise in the progesterone level, which is an important thing which is there. And that happens only with a GnRH agonist and doesn't
No,
happen.
no, you are right. I do agree, but that is to
Yeah.
be done on the trigger day itself. I mean that
No,
that
no,
should be
but
done
then
if it is.
that's what most papers over there, they say that after you give a GnRH agonist trigger, it's best to do both LH as well as progesterone. And I also differ from the panelists saying that 225 is the minimum dose, because if it's a PCOS wherein you have because most of the protocols are individual protocols and it depend upon AMH and antral follicular count both. So if you look at Scott or Lamarca's articles, both of them have said that you have to take into consideration both AMH as well as antral follicular count. And if you have a AMH between 3 to 8, I think you should not start with 225. I think it's
150
best to start with 150 because at least in my practice, and in my practice, I do a lot of fresh transfers, even in a PCOS patient, because what I aim at basically is only about 8 to 10 follicles. Because we don't look at the epigenetic changes which are happening when you're freezing and thawing. And if you look at the newer papers which have come, though at one stage they said that you do freeze for all, but now they're saying freeze all should be done only in indicated cases, like where there is a definite risk of OHSS, where you're doing fertility preservation, wherein you're going to do a PGT. In these cases, basically, you do a freeze all. But in all other cases, it's best because there are no studies which have really been published what is happening to the babies later on. And there are 1 or 2 papers which said that probably there is a long-term a problem because of the epigenetic changes which happen because of freezing and thawing, because you're taking the embryo from 37 degrees to minus 197 and again getting it back. So wherever possible, I think it's best to do a fresh embryo transfer. And
I think we must read Lamarca's paper. I think he has done an excellent work on this predictors, AMH and AFC and age.
So he
and
has
I think
mentioned both AMH and antral follicular count should be done, especially more so in PCOS and poor responders. So if it's a normal responder, your AMH and antral follicular level really does not make a difference. But in patients who are poor responders and hyper responders, all your protocols should be decided on the AMH and antral follicular count.
So, hello everyone. This is Vikas Singh. Good evening to all. So, I am from the medical team of UNS. So, I would like to thanks to everyone. So, just wait for I have prepared some thanks note. So, I hope my slide is visible. So, first of all, on behalf of Universal NutriScience, I would like to thank President ISAR, Dr. Amit Patki sir, and Dr. Asha Bakshi ma'am, to Secretary ISAR, to give UNS the opportunity to organize such a significant webinar series. Further, a special thanks to our conveners, Dr. Anu Agarwal and Dr. Fessy Lewis, for helping all the IVF specialists to bring together to one platform and planning such a beautiful event with UNS and helping Universal NutriScience to plan such an impactful program. Further, I would like to thank our chief guest, Dr. Nandita Pal Shetkar ma'am, and guest of honor, Dr. Bhaskar Pal sir. Thanks for joining in and enlightening today's program. Further, all the chairperson, Dr. Anuradha Khanna ma'am, Anupama Futela ma'am, Veronica ma'am, and speaker, Dr. Madhuri Patel, Anupama Patel ma'am, and all moderator, Dr. Kundan English sir, and all the panelists for your presence and guidance. So thanks to, and lastly, I would also like to thank to every participant and contributor and to the event manager RX event. So, and last but not the least, from once again, I would like to thank on behalf of Universal NutriScience to all the participants, speakers, and chairpersons and all. Over to you, Dr. Anu ma'am or Dr. Nakul, if you would like to give some thanks.
Dr. Fessy?
Yes, I can hear you. My video, I am not able to on it. Someday is blocked.
We can hear you.
Okay. I think all the effort was made by Anu for arranging this webinar. I think I was busy. I could not at last because of personal some commitment. I think the schedule is that every month, first Tuesday is the schedule. I think Anu will brief about that, so that all we are looking forward for a new topic next month. I need all the seniors guidance for that. Over to you, Anu.
Thank you. Thank you, Madhuri madam. You thought so many good, so many take-home messages, so many things to learn from you. Thank you. So we'll meet next month on the first Tuesday with new topics. Thank you. Thank you, everybody.
Yeah, Doctor, thank you. Thanks from UNS side. Your valuable presence during this series too. And definitely means there is a lot of insight to all delegates. We appreciate your that's engagement. Thank you. Thank you very much.
Good night.
So, yeah. Ma'am, just I want to quick highlight, total delegates for today's webinar, 332. 332 faculty members 18 and UNS team members 34. Total attendance was 384.
435. Current is 435.
Yeah, current is that 435.
435.
Yeah.
People can see it after that. Also. After the live, also people can see, so that attendance will be more.
Now everybody is waiting for the dinner.
That's true.
Okay. Okay. Good night.
Thank you.
Good night.
I request RX team, event team, please stop the recording.
Okay.
Recording stopped.
Hello. Yeah, doctor. Thank you very much. Thank you, Dr. Anu. Really thanks.
Thank you. You all did a wonderful job.
Thank you, ma'am. Ma'am, just quick highlight that you are saying that few duplicate values are there. Means किसी ने double login किया है ना, तो इसलिए that 4 इतने दिख रहे हैं. तो actual number is 384, doctor.
Okay.
मैं एक just collage बनाया है, तो मैंने just group पे भी share किया है. I'm sharing that on group.
Next webinar और अच्छा करते हैं मैं. और plan
Definitely.